Hello, everyone. I'm Dr. Galen, Henderson, Department of Neurology, Brigham and Women's Hospital, Director of the Neuroscience Intensive Care Unit, and I'm here to talk with you today regarding advances in stroke. I have no conflicts of interest to disclose. Here is going to be the outline over the next 45 minutes or so. We'll talk about issues of ischemic stroke followed up by cerebral hemorrhage. In regards to ischemic stroke, this is something that's incredibly common. There are around 800,000 new and recurrent strokes each year. Stroke is the third leading cause of death. Some form of heart disease is number one, some form of cancer is number two, stroke is number three. But stroke is one of the leading causes of serious long-term disabilities. And as patients get older, they're more concerned regarding being disabled. This is one of the most serious disablers in the country we have. So we should be very serious about this disease entity. In regards to estimated outcomes after ischemic stroke, 5-year recurrence rates can be high, ranging from 25 to 40%. 5-year stroke mortality is high, ranging from 40 to 60%. And still, the number one cause of death in stroke patients is heart disease. 24 to 53% of patients are still functionally dependent at some capacity, and for those who do survive, about a third of those patients have some signs of dementia. So I know people are concerned about Alzheimer's disease and that form of dementia, which is very serious. But if your patient has had stroke or TIAs, please consider vascular dementia very high on the list. We're going to focus primarily on ischemic stroke, which is about 88% of all stroke. We will focus on cerebral hemorrhage later. In regards to this disease, remember that ischemic stroke is a very heterogeneous process. On the left side of the screen, you see issues of atherosclerosis, similar to that for heart disease. On the right side of the screen, you see issues of other causes of strokes, dilated cardiomyopathies, atrial fibrillation, vasculitis causing strokes. Some patients may have arterial dissections in their carotids or vertebrals. Patients may have prothrombotic disorders, factor V Leiden, lupus anticoagulant, antiphospholipid antibody syndromes. So there are many, many different causes of stroke, and it really depends on the risk factors and the scenario, what may have happened. They all cause blood clots. That blood clot blocks an artery, which causes permanent disability. In thinking about those patients on the left side of the previous slide, those with atherosclerosis, remember that many of these stroke patients will have issues of peripheral arterial disease. This is a very important marker to note, knowing that in this small study, they saw that about a half of the patients had ankle brachial indexes less than 0.9. And as a result of this study and other small studies, we started checking ankle brachial indexes and found that 20 to 30% of our patient population in the stroke clinic also had peripheral arterial disease. These were people who did not have known disease, and this was incredibly important in understanding the patient and their overall risk burden of vascular disease. In regards to risk factors, there are two groupings for risk factors: modifiable risk factors and non-modifiable risk factors. For non-modifiable risk factors, age. After age 55, for each successive decade, the risk of stroke increases or doubles. Gender, males have more strokes than females. Race and ethnicity, those of African descent or Asian descent, along the Pacific Rim, the risk of stroke is twice as that of Caucasians. And if there is a family history of stroke, we want to be aggressive with controlling those modifiable risk factors that you see on the left. In regards to the weighting of what these risk factors are, no surprises here. Hypertension is by far the number one risk factor. Many people are usually surprised towards the bottom of this slide. There are psychological factors such as stress and depression that can also be risk factors for stroke. It is just as important as having the diagnosis of diabetes that you see towards the middle of the slide. So these are all important issues, and it's important when we're taking care of patients to take care of the whole patient and not just a small category within the patient. Prevalence of stroke by age. Yes, we do see strokes in older patients, but if you notice that about a third of patients are actually less than age 65. It is not uncommon for young people to have strokes in their 20s, 30s, and 40s, some with risk factors, some without risk factors. We seem to all be playing this game of Russian roulette, regardless of those risk factors. But we do see more strokes in older patients and less focus on those older patients because the number of people 65 years of age and older, that number is going to be growing over the next few decades, as well as those people 85 years of age is growing as well. And if the rate of stroke continues as it is, in about 2 or 3 years, we're going to have more than 1 million strokes per year. And switching gears, let's talk about TIAs, transient ischemic attacks. Well, the definition has changed, and this is the old definition, neurological symptoms that resolve within 24 hours. This is no longer the definition that we are using. This is the newer definition that you see here. So the clinical symptomatology is the same, but now symptom must have a time limit of 1 hour or less. So it must be less than 1 hour and without evidence of infarction. This brings about imaging. Imaging is a core part of how we are evaluating patients. Imaging now is our marker. Cardiologists, they have biological markers such as troponin, CKs, they have neurophysiology, EKGs. With us, we have our exam. We also have radiographic markers, and I'll say more about those imaging studies in a few minutes. In looking at the old definition of TIA, that 24-hour mark, remember that 24 hours was not something that was validated. It was based on consensus. But using that old data, there was a study in California looking at a group of 1,700 patients. They were presented to the emergency department with and given the diagnosis of TIA. They had a head CT, which was normal. Their exam was normal. And the patients were told, you've had a TIA. Your symptoms didn't last for a full day. We're going to send you out and get the rest of your workup as an outpatient. Well, they followed their medical records over the next 90 days, and it turns out that 10.5% of those patients had stroke within that 90-day period. 12.7% had recurrent TIAs. For those patients that had stroke, half of the patients that had events over the next 90 days, half of those events occurred within 48 hours of being discharged from the emergency department. The people who were at high risk were those who were above age 55, if they had a history of diabetes and stroke in the past, and if their symptoms lasted for more than 15 minutes, they were considered high-risk patients. As a result of this study, as well as many other studies, we are trying to categorize which TIA patient is a higher risk patient versus a lower risk patient. So this is what we use, the ABCD squared of TIA. It's a point-based system. So A is for age, B is for blood pressure, C for clinical features, D for duration, and the second D is for diabetes. And if you were to score 6 or 7 on this scale, your overall 2-day risk is 8.1% for having a life-threatening or disabling stroke. So this number is incredibly high, and this is helpful. And we will make decisions based on the ABCD squared that is obtained at the initial evaluation in the emergency department or in clinic. In regards to whether or not we should admit TIA patients to the hospital, there is some guidance on this. So the guidelines say that it is reasonable to hospitalize patients with a TIA if they present within 72 hours and they have an ABCD score of 3 or greater. If the number is smaller and we can't get the workup within the next 2 days, which is 48 hours, we probably should admit them to expedite the workup. So it's similar to that for chest pain. If you're seeing a patient with chest pain within 72 hours, chances are you're going to send that person to the emergency department. Greater than 72 hours out, you probably will not send that person to the emergency department and get that workup as an outpatient. It is the same for the neurovascular patient. What we're asking people to do is more of an evaluation of these neurovascular patients to making sure that the problems with the arteries are resolved and that those arteries are open. And working up a TIA is basically the same as working up a stroke. It is the same disease. If you're having TIAs, you have end organ disease. If you're having chest pain, you're having end organ disease. The guidelines say we want imaging of the head and neck, meaning the entire neurovascular tree. We get more information from diffusion-weighted imaging, MRI, compared to CAT scans. But we have to use what is available to us, and I'll compare the two in just a second. But we also want evaluation of the heart with EKGs, echoes, and Holters. So we want to clear those vessels, make sure those vessels are open, making sure that the heart does not have a clot in the chamber anywhere. In regards to imaging, I'll make note of CAT scans first. There are many advantages. They're very fast, easy to get, sensitive to cerebral hemorrhages, but the downside is that they're often normal in the hyperacute phase. It looks completely good. They're very insensitive to lacuna and posterior fossa strokes, but they have their role in regards to the acute management of patients. Whereas MRI technology gives us so much more information compared to CAT scans, but they're logistically more difficult to get. They're not available at every place, longer scanning times. The patient may have contraindications, they get sick in the scanner, they vomit. There are a lot of logistical issues that may arise with diffusion-weighted imaging MRI. But if people have symptoms for more than 30 minutes, chances are, if it's going to be a stroke, you're going to see it with this particular study, whereas you may not have seen it with the CAT scan. Here are 3 patients with CAT scans above and MRIs below. With the first patient, we see a large, this scan looks mostly normal. This is a CAT scan. Below is the DWI, diffusion-weighted MRI, and we see this large right middle cerebral artery stroke. This patient's prognosis is poor. We expect a much worse outcome compared to a small artery stroke because this is a large territory. 10 to 15% of these patients will have to go to the intensive care unit for protection of their airway or for cerebral edema related issues. We do expect this patient to need a temporary feeding tube because we expect them to have prolonged difficulty with swallowing. Patient number 2, gross and normal looking CAT scan above and below. There's a thalamic stroke, even though the patient is completely paralyzed, looking very similar to that of patient number 1. Patient number 2, the outcome is going to be much better simply because the stroke volume is a very small stroke volume. And patient number 3, also from a scan that looks relatively good above, but their MRI below shows multiple white matter changes in different vascular territories, suggesting a proximal source or aortic arch disease. And so when we evaluate this patient, we really are going to be looking at the heart very closely. There are multiple ways of looking at the vessels or clearing those vessels. I'll make comments regarding the first 2 types of imaging modalities that we see here. So for those patients that are getting CAT scans and they're symptomatic coming into the emergency department, we will get a CT of the brain and CTA of the head and neck. This is something that's easier to get, and this is an example of what was seen, which was a threatened carotid lesion that was about to be sent out of the emergency department. But we saw this gentleman, scanned him, surprised that there were no carotid bruits, and the patient stayed for his carotid procedure. The image on the right side of the screen, this just shows us that we can orient these images from various vantage points to see if there's any stenotic lesions anywhere. Also, we must look at the intracranial circulation because we see more intracranial disease than extracranial disease. 8 to 9% of all ischemic stroke are from intracranial atherosclerosis. It's important to know about this. For those patients that are getting MRs of the brain, we do want MRAs of the head and neck. This is a very tight carotid here, and a missing left ICA here. We'll see the vertebral arteries, the right and the left. So evidence tells us that within 12 hours, yes, we get so much more information from diffusion-weighted MRI imaging. But we have to use what is available to us. And if it's going to be a CAT scan, that's fine. We can use a CAT scan. If it's going to be an MR, use that MR or some other type of urgent, non-invasive imaging modality. In regards to medication treatments, I have aspirin here within 48 hours. I just want to make a note that the dose of aspirin does vary. We see studies suggesting 30 milligrams a day up to 1,500 milligrams a day is equally effective. The relative risk reduction is around 18 to 22%. Relative risk reduction for secondary prevention of stroke. We don't think of aspirin as being a primary preventative tool. Heparin and heparinoids are considered for DVT-PE prophylaxis and is important to start usually within 24 to 48 hours of the patient becoming plegic on that side. The gold standard has been the treatment of ischemic stroke with intravenous TPA, which was first approved in 1996, and only 8% of ischemic stroke patients are eligible for IV TPA. Because there is a narrow time window and people are concerned about that risk for cerebral and systemic hemorrhages. And it only achieves reperfusion in 13 to 50% of cases where there's large vessel lesions. We know that within 3 hours, this drug of TPA is FDA approved. We do not need permission. We treat everyone who's eligible within 3 hours. 3 to 4.5 hours, that is the extended criteria window, and there are certain patients that we are able to treat in this extended criteria window. The criteria are the same within 3 hours for the 3 to 4.5 hours, except anyone with a history of diabetes and stroke, anyone who's above age 80, or have a very high NIH score greater than 25. We are not going to recommend that they get treated intravenously with IV therapy. And for those patients that can't be treated intravenously through IV therapy within 4.5 hours, we recommend catheter-based therapy. With a meta-analysis showing strong correlation between revascularization and good outcomes, we know that patients do better when the vessel is opened compared to when it's not opened. The size of the clot does make a tremendous difference, and it seems that when the clot is somewhere between 5 and 6 millimeters, they're less likely to open with IV therapy. And when we look at the overall mortality rates of internal carotid artery, middle cerebral artery, and basal artery occlusions, this is quite serious. As of 2 years ago, in 2015, there was a new era, a new paradigm shift in regards to how we treat patients and the standard. I'm going to show you an example of a class of endovascular devices called a stent retriever. I don't have any relationships with any companies. This is something that I pulled offline that you can pull yourself. And here are some studies. The first two studies, IMS-3 and MR Rescue, were negative studies, but here are 4 studies, and there are additional studies published in the New England Journal of Medicine showing us that catheter-based treatments of people with middle cerebral artery lesions and they're treated with endovascular stent retrievers, and recanalization rates are incredibly high. Their outcomes are just strikingly different than a person who would not have gotten that artery open. So this is an example. This is a cartoon of a patient having a stroke. We see this emboli. Lodges in the distal middle cerebral artery. We see in the angiogram that there's no flow. Things are blocked right there. The device, they look like a stent, but also you're able to retrieve things with this stent retriever. The device is eventually deployed over a guide wire through the clot itself. When the device is fully deployed, it actually pushes the clot to the outside of the vessel or to the inner wall of the vessel. And the device opens up. When it does open up, it promotes flow. When the device is deployed, there is some antegrade flow, and we see blood flowing already. Proximally at the internal carotid artery, we balloon occlude the vessel, and we pull back. And we pull the clot out. So this is now the standard of care when it comes to large vessel strokes. We have multiple trials, randomized trials, showing the benefit of this type of technology. I think what we're going to see over the next few years are things similar to what cardiology learned about 20 years ago in how they transitioned from IV therapy to catheter-based therapies and the promulgation of that technique. We expect to see the similar type of promulgation of this technique hopefully at a faster rate than it was adopted for the heart. And just an example of the clot's in place. Now the vessel's open and we can actually send the clot for pathological studies. In regards to endovascular interventions, we have guidelines supporting this. This is not FDA approved, but many organizations support this type of treatment. So these patients should have the following: pre-stroke MRS score of 0 to 1. Even if they've gotten IV therapy, we're still recommending if we visualize that clot on CT angiogram or MR angiogram early on to take these patients for catheter-based therapies. They're typically 18 years of age and older with aspect scores of greater than 10, and this is a way that we can estimate collateral circulation based on the CAT scan. We want groin puncture within 6 hours of symptoms onset. As with IV TPA, reduced time from symptom onset to reperfusion with endovascular therapies is highly associated with better clinical outcomes. And to ensure this benefit, reperfusion to TICI grade 2B3 should be achieved as early as possible and within 6 hours of stroke onset. When treatment is initiated beyond 6 hours from symptom onset, the effectiveness of endovascular therapy is uncertain for the patient with an acute ischemic stroke who have causative occlusions of the ICA or proximal M1. Observing patients after intravenous TPA to assess for clinical response before endovascular therapy is not required to achieve beneficial outcomes and is not recommended. So everyone who's eligible for IV therapy, they get it. Everyone who's eligible for catheter-based therapy, they get it. And what is the time to treat? Even though the guidelines say one thing, we may be able to expand that window. And I think imaging in the future will help determine which patients may benefit being outside of the 6-hour window for therapy. Since we're trying to figure out ways of treating more people, there have been multiple pilot studies internationally and in the United States regarding putting a CAT scanner in an ambulance. And this has shown that we're able to treat more people in the field with this type of early imaging technique and point of care testing of blood work. And even with the telestroke organizations, typically there is a central hub with smaller hospitals calling into the larger hospitals for assistance. Physicians at the larger hospital answer all questions and give the authority to give intravenous TPA. And it allows neurologists to expand their territory of coverage. Switching gears, lowering blood pressure. Now, when we see something like this is the old JNC 7 criteria, there are JNC 8 criteria. This is just for outpatients. This is not for the acute patients that you're going to see in your office or your clinic or the emergency department. This is somebody who has been treated and we're tweaking their blood pressure medicines to something tight like this. For those people who are not going to be eligible for thrombolysis, which is the vast majority of the patients, we let their blood pressures ride high. So we want the systolics less than 220 and diastolic less than 120. And we should not be in a rush to lower that blood pressure because sometimes the brain needs that additional perfusion pressure. So after a few days, we will put the patient's blood pressure under control, under better control. And after several weeks or so, we try to make sure that this patient has very tight control of their blood pressure. For those people who are eligible for TPA, yes, we do want their blood pressure down because of that risk for having a hemorrhagic transformation is going to be higher. So we are more aggressive with lowering their blood pressure. So in regards to blood pressure control, we do think of this as a primary preventative tool and a secondary preventative tool. We can reduce stroke by 35 to 40%. Thiazide diuretics are recommended as a first-line agent, but we do like ACEs and ARBs for diabetics. With antiplatelets, which one to choose? Well, it's nice to know that we do have choices to choose from. There is no evidence that switching from one type to another is beneficial. And so we recommend whatever the patient is able to tolerate. Which antiplatelet is better? On recommendation of the recommended antiplatelet regimens, we suggest clopidogrel or aspirin and extended release dipyridamole, which is the Agonox compound, over aspirin, or solustazole. Are we saying that we shouldn't try aspirin early on? The answer is no. We do have choices, and depending on the patient's side effect or clinical scenario, or profile, or presentation, we should determine which one is going to be better for that patient and stick with it. What may happen in the future, but it's not ready for prime time, are things like this. This was a Chinese study called the CHANCE study, clopidogrel with aspirin in acute minor stroke, or TIA. And it was a 3-month study looking at the loading of patients with clopidogrel and aspirin compared to them to aspirin alone, and reducing the 3-month risk of a new stroke when started within 24 hours of symptoms, and when they were deemed at a high risk. These patients were all Chinese virtually. They were above age 40 or greater. They had non-disabling stroke and scores of 3 or less, or they had an ABCD squared score of 4 or greater, and they started drugs within 24 hours of symptoms. Here are the results. Primary outcomes show that the combination therapy did better for primary stroke outcome, as well as secondary combined outcome. Other antiplatelets were tried in combination therapy, and what they did see was more cerebral hemorrhage. CHANCE summary: TIAs and minor strokes are treatable emergencies. In this particular trial, the loading of clopidogrel 300 milligrams plus aspirin reduces subsequent stroke risk, and the FDA has not approved this line of treatment because it requires 2 independent neurologists, 2 independent studies showing the same results before this is FDA approved. So there are other trials that are ongoing right now that will be looking at this to see if this is something that we should be doing. But right now, we don't know. It is very interesting. We do know that for those patients with atrial fibrillation, to determine if people need to be anticoagulated, please use the CHADS, or preferably CHAD-VASc score, and then choose which of the newer anticoagulants you're going to be using. I put here a table for reversal of anticoagulants that people should look at, because I think it does, it is handy. In regards to statins, statins are incredibly important. We know that they're good for primary and secondary prevention. These statins received a lot of attention after the Sparkle study. We're not recommending this particular statin or this particular dose, but those people who were involved in the study did not have known heart disease, and they had less events while on a statin, and their events were less severe in nature. Overall now, in regards to the ACC and the AHA, recommendations are based on a 10-year risk for cardiovascular disease, and it shifts away from specific cholesterol goals, although that can be monitored as well. Atorvastatin, 10 milligrams is considered moderate intensity statin treatment, and 40 to 80 is considered high intensity. Outstanding for primary and secondary prevention of stroke. There are multiple types of stroke centers. There's the primary stroke centers, the ability to give intravenous TPA, and there are comprehensive stroke centers which usually will have catheter-based therapies. We know that standardization does provide better outcomes. This is a proof of concept study called the PROTECT trial. We see the old population in yellow. The new population in blue. After quality improvement program was put in place, the number of people with antithrombotics, statins, ACEs and ARBs, thiazide diuretics improved with standardization. This is proof in the pudding. Stroke rates used to be as high as 16% 90 days out from the overall initial event, and it went down to 2%. Stroke centers give better care, more people going to home or to rehab, and nurses become specialized. They can anticipate problems. It becomes a well-oiled machine. With the workup of a TIA and stroke, remember it is the same. I'm going to say more in a second regarding Holter monitoring that you see on the left in the left column. With atrial fibrillation, there was a study published in the New England Journal of Medicine which looked at Holter monitoring for 30 days compared to the 24-hour monitoring. For the 30-day monitoring, they saw that 16% of patients will have atrial fibrillation. With 3-day monitoring, only 3% of patients were found to have AFib. And it seems that the longer we monitor people, the more AFib we actually find. And we don't know how long we should be monitoring these patients. As an institution, we have said, okay, for us right now, maybe 2 weeks is appropriate enough to monitor these patients. The rest is actually monitored by family members of the patient. So these were patients in this trial who were above age 55, and the 30-day evaluation time in this study improved the detection of atrial fibrillation by a factor more than 5 and nearly double the rate of anticoagulation being used. So this is something that will change therapy. When people are discharged, we do want them on their blood pressure medicines. We want them on antiplatelets, and we have to figure out which one is going to be appropriate for them and stick with it. And of course, we always encourage statins and lifestyle changes. This is a slide to help me remember to tell you that in regards to patients on this list, such as Peyton Foraminal Valley, when we do see PFOs, right now we have 3 trials that are negative for the benefits of closure of PFOs. So if we were to see a PFO, yes, it is worth performing a hypercoagulable workup, seeing if the carotids have clots, if the heart has clots or DVTs in this patient population. If you were to see stuff like that, it will change therapy and you will put that patient on anticoagulation. But if nothing is seen, if there's no hypercoagulable state, no clot seen in the MR of the pelvis or deep vein thrombi, we tend to put those patients on just aspirin. In regards to carotid dissections, we agree that something should be done, meaning either aspirin or anticoagulation. With intracranial atherosclerosis, so we do like high-dose statins. For those patients that are women, we do know that there are specific issues that must be discussed, but unfortunately we don't have time to discuss all of these additional issues. I encourage you to evaluate the guidelines from the American Heart Association. It discusses issues of pregnancy, preeclampsia, hormonal changes, and postmenopausal hormone therapy in that patient population. The significance of cerebral hemorrhage is great because unfortunately, despite all of the things that we try to do, we have not been able to change any outcomes or mortalities over the past 30 years or so. And only 20% of patients live independently at 6 months after a cerebral hemorrhage. Here are the different types of cerebral hemorrhage. I will talk a little bit more about primary hematomas, which are usually secondary to hypertension or the deep hypertensive hemorrhages. Here's more common places where these hypertensive hemorrhages occur. We do know that the size of the hemorrhage makes a tremendous difference, and we think about it in the terms of a ping pong ball. One ping pong ball is about 28 milliliters, or 28 cc's, or roughly 30 cc's. One ping pong ball is considered a low volume type lesion that patient is going to live. If it's two ping pong volumes worth of hemorrhage, it is more guarded. 3 or more, we don't expect that patient to live. We know that when people present with their cerebral hemorrhages, a certain percentage of those hemorrhages will grow over the next 24 hours or so, causing more disability. Here's an example of a ping pong ball on the top right. Bottom left is a golf ball, and one is much larger than the other. Even though visually it looks about the same, these volumetric differences are quite striking. Contrast within the hematoma is very helpful for us in determining where the spot sign is, and this is extravasation of contrast within the affected area. This shows us that the patient is actively bleeding, and we expect to see this in patients where there's going to be a growth in cerebral hemorrhage over the next 24 to 48 hours. With all cerebral hemorrhages, we must calculate the ICH score. This is how, these are the components of the ICH score. They help predict overall outcomes. And the FUNCT score, which predicts long-term outcomes at 90 days. Guidelines for blood pressure control. Yes, we can get that blood pressure down, but we really don't want to push it down too greatly because we've seen from additional randomized trials from the ATTACH study that pushing the blood pressure below 140 actually causes kidney damage from hyperperfusion. So we want to be careful with blood pressure in this patient population. And the goal is typically somewhere between 160 and 180 systolic. This is rapid blood pressure lowering in patients with acute cerebral hemorrhage. Trial was involving the patients, and they wanted to lower their blood pressure less than 140, but it did not reduce the rate of primary outcomes such as death or major disability, but did significantly reduce the overall functional outcomes. Overall, this was a negative trial. Despite how this phrase is written, this was a negative trial. Surgical therapies, sometimes when patients do have lesions, neurosurgery is called, but the only times that they're truly beneficial is if an external ventricular drain is going to be placed for hydrocephalus, or if they have a posterior fossa lesion 3 centimeters or greater, because they can perform surgery, decompress the posterior fossa, keep the brainstem from being compromised, and we have a system in place to treat these patients. Overall, surgery for cerebral hemorrhage have all been negative in regards to randomized trials. And this is an example of the STITCH trial, which is a little over 1,000 patients. And when we start DVT prophylaxis, as I said, that we do want to wait a couple of days before we start either heparin or things like enoxaparin. For those patients who are mental statuses are not quite what we expect, we may want to get continuous digital video EEG to evaluate for subclinical seizures. And it is true, the more we evaluate those patients for epilepsy or seizures, the more we actually find. So overall, ischemic stroke, we've talked about the epidemiology. We're going to be seeing a lot more of these over the next few years. We're going to have imaging as a core part of how we are evaluating these patients. It is more about imaging now than the actual clinical time that we once thought was required for a stroke or TIA. We talked about thrombolysis and the extended thrombolysis window, and catheter-based therapies, which is a new paradigm shift. With cerebral hemorrhage, not as much, but that number is fairly constant in regards to its epidemiology. Imaging is important, looking for the spot sign. So even though there's a hemorrhage on the CAT scan, we will give contrast and scan them a second time. Prognosis, please use the ISAIC score to help give some guidance, and remember that certain patients will have subclinical seizures that can affect the clinical exam, so please have this performed before the attending comes. Additional things such as reversal agents. For warfarin, we use protein complex concentrates. Question number 1. Mr. Jones has 3 hours of sudden onset dysarthria, arm and hand weakness, and then symptoms completely resolved. Is this A, stroke, B, TIA, C, RIND, which is reversible ischemic neurological deficit, D, migraine? The correct response is A. This definition is less than 1 hour and negative imaging. Reversible ischemic neurological deficits is no longer a valid term, and migraine symptoms are not sudden. Migraine symptoms tend to march. Vascular TIA and stroke events are very sudden. Question number 2. What is the most practical method for cerebral imaging study within 3 hours of stroke signs and symptoms? A, CT of the brain, B, CT of the brain, CTA of the head and neck, C, MRI, D, MRI of the brain and MRI of the head and neck. The correct response is B, CTA of the head and neck is the most practical cerebral imaging study in emergency department ICUs and for other inpatients. And from this, we can actually visualize a large vessel lesion. Those are the ones that we will take to catheter-based therapy. If the lesion is beyond the resolution of the CAT scan, that's one thing. But question number 3, Mr. Jones is 83, right-handed, has an NIH score of 12. Witness onset of his stroke is within 2 hours with a negative head CT. The correct response, A, he's too old to be considered for TPA. B, give aspirin only. C, if there is no problem, no protocol exclusions, give TPA. D, give clopidogrel only. The correct response is C. In giving IV TPA within 3 hours, that's important, and there's no age cutoff for within the 3-hour time window. Aspirin or clopidogrel should be given as soon as possible, but not as a TPA candidate. Question number 4, which is the most appropriate antiplatelet therapy for non-cardioembolic stroke? A, aspirin, B, clopidogrel, C, the Aconox compound, D, aspirin and clopidogrel, E, any of these above. The answer is E. Ischemic stroke is a very heterogeneous disease, and the treatment regimen depends on the etiology of the patient's ischemic event. Question number 5. How do I work with a patient with the diagnosis of TIA? Cardiac echo, EKG Holter, brain imaging, vascular imaging, all of these above. It is E, all of these above. Echo is to rule out a PFO and to evaluate ejection fraction. EKG and Holter to rule out AFib. we always need brain imaging and neurovascular imaging.